Okay. So welcome back, all of you. I welcome you to the thematic session 2A, Data Systems at Scale, Strengthening Infrastructure Quality and Use. To moderate this session, we have Dr. Ji-Yoon Ra, who's the Deputy Representative in UNICEF Nepal Country Office, leading and managing all stages of multidisciplinary programming process in the country. She's an international development and public health professional with 20 years of academic and programmatic experience in diverse contexts. Welcome. Our second chair for the session is Dr. Mugdo Mazab, who's a research fellow with the Poverty, Gender and Inclusion Unit in Dhaka, Bangladesh. He is a development economist with research interest in environment, health, and political economy. He received his PhD in economics from University of Virginia. Over to you.
Namaste. Good afternoon. Good afternoon, yes. We all had lunch, no? This is just after, right after lunch. But good afternoon once again. Yes. I have been introduced already, but let me just briefly introduce myself again. My name is Ji-Hyun Ra, but please, you can just call me G. In Nepal, I am Gigi, by the way. Yes, I am from UNICEF Nepal Country Office, and I'm currently working as Deputy Representative. But then before I transitioned to a management position in UNICEF, I used to belong to nutrition section. I was, working with nutrition colleagues, so always being back in a nutrition conference or nutrition meeting feels very special and personal to me. So wonderful to meet all of you. Today, I am so delighted to have an opportunity to co-chair the session which focuses on data systems at scale. Yes, there are many different types of data, but especially today, we are to talk about data systems. And today's discussion, and we have 6 presentations in line, all the presentations will focus on how can we strengthen data systems at scale by strengthening infrastructure quality and use. But before I say anything further about the session, let me also hand it over quickly to our co-chair for his introduction. Yes.
Thank you, Chi. Good afternoon. Namaste, everyone. I'm Dr. Mahazab. I'm a research fellow at Poverty, Gender Inclusion Unit at IFPRI. I'm a development economist. I joined IFPRI last year, June. Prior to that, I did my postdoctoral fellowship at Stanford University, where I concentrated on public health, nutrition, and environmental work. It's a great pleasure to be back to D4N, and a wonderful organization, wonderful credit goes to the organizers, and we have a brilliant set of presenters presenting some work on data at scale. Without further ado, I'll pass it on to G to introduce our first presenter. Thank you.
Okay, thank you. I recognize some of my old friends and colleagues in this room, and I really don't need to talk about the importance of data to you. Perhaps some of you are, more of an expert than myself in the area of data. When it comes to data, of course, we have to ensure robust methodology and approaches in data collection. But at the same time, when it comes to data, we all understand that the proper utilization of data is equally important to inform policies and programs. We all understand that there are different types of data, small, large. The purposes of the data can be different as well. But then regardless of the type of data or the source of data, we know that each one has its own unique purposes and use. The session today, among different types of data, we will particularly focus on data systems, the 2 data systems at scale. And we will be listening from 6 presenters, and each presenter will talk about what are some of the latest developments in this area of data systems at scale, what new ideas and concepts are currently being tried out to strengthen data infrastructure, quality, and use to improve the data systems at scale. So without further ado, I'm going to be starting to introduce our presenters today. The first presentation is going to be delivered by Miss Anjali. Can we have Miss Anjali on stage? Yes. She's going to talk to us. She's going to deliver a presentation on the potential use of high-frequency price monitoring tool to track the cost of healthy diets over time. It is, this presentation is based on a case study from, which was conducted in rural Bihar state in India. Over to you, Anjali.
Good afternoon, everyone. I am Anjali Purushottam from the University of Sheffield. It's very great to be part of this conversation and being with all the incredible research on nutrition in South Asia. Today, I will be talking about some of our work I'll be talking about some of our work around rural food markets in Bihar, in India. Particularly, I'll be focusing on the potential of a high-frequency price monitoring tool to track the cost of healthy diets over time. This is the work that is conducted in collaboration with many researchers in Sheffield, London School of Hygiene and Tropical Medicine, and many more partners in India. So without further ado, let me start my presentation by highlighting that in recent times, India has been experienced repeated and large price volatilities, particularly so for the perishable fruits and vegetables. And much of these price fluctuations are often driven by extreme weather shocks, disruptions in supply chains, inadequate storage facilities, as well as short-term policy responses. In addition, these price fluctuations have strong implications for the cost and affordability of healthy diet because many of these perishable fruits, vegetables, and animal source foods constitute an essential component of a healthy diet. So against this backdrop, there is a pressing need for mechanisms that can accurately and quickly capture these rapid changes in food prices over time and space. So to this end, in this study, we assessed the potential of a high-frequency price monitoring tool in capturing the responsiveness of the minimum cost of a healthy diet to the volatility in rural food prices, and to identify the periods and regions when healthy diets are least affordable. For this, we have established a scalable price monitoring system in around 255 informal rural food markets that were selected following stratified random sampling procedure across 2 districts in rural Bihar. So the map here shows the 2 study districts as well as the spatial distribution of sample markets in the study districts. So in each of these sample markets, we collected bi-weekly prices for 17 commonly consumed fruits, vegetables, and animal source foods in the region for about a year, starting from July 2024 until the end of August 2025. In addition, we also collected the prices of other food items such as grains, pulses, nuts, seasonally for about 3 times a year, again during the same period as the previous high-frequency price monitoring survey in the sample markets. And to calculate the cost of diet, we first used the recommended national dietary guidelines for men, women, and children. These national dietary guidelines provide specific amount of quantities that to be consumed in 8 essential food groups, such as cereals, pulses, nuts, dark green leafy vegetables, fruits, other vegetables, dairy, and meat. And secondly, for each sample markets and for each day of price data collection, we identified the lowest cost food item within each of these 8 food groups. And finally, using this low-cost food price matrix and complementing it with the national dietary guidelines, we calculated the minimum cost of a healthy diet for men, women, and children. In the subsequent slides, I'm going to talk about some of the preliminary results using an exploratory analysis to understand how these everyday changes in food prices are associated with long-term as well as short-term volatilities in the cost of healthy diet. Here, some of the descriptive statistics, we can see that the minimum cost of a healthy diet for men, women, and children ranges from about 54, 45, and 38 Indian rupees per day. We can also see that the lowest absolute and relative variance in the cost of healthy diet is observed for children, whereas for men and women, there is quite wider spread in the diet costs, as indicated by their absolute and relative variance. Here I'm presenting the trend of the minimum cost for men over time. From this graph, we can particularly see that there are 3 distinct phases of cost movement. To start with, there is a consistently high cost, particularly around the time of July and December 2024, which is followed by a sustained low-cost period, again from Jan to April 2025, which is then immediately followed by a steady increase in diet costs from around May 2025 onwards. Here particularly, if we see the mean prices as well as their 7-day moving average, they're much closer to each other, indicating that the daily prices sort of present the underlying trend over time. And when looking at the volatility and spread components from this graph, it is further highlighted that the both high cost periods, which are the consistently high cost, as well as the steady increase in cost during late 2024 and mid 2025 are the periods that have that experience high volatility in prices as well, as compared to the sustained low cost period during early 2025, where the diet costs tend to be more or less stable. And in addition, these long-term price trends are scattered with several short-term spikes and dips in the diet costs, which are associated with the price fluctuations of specific fruits and vegetables like tomato, eggplant, banana, and spinach and other perishable food items. And one more common pattern is that here for brevity, I'm presenting the diet cost for men, but the patterns and trends of price diet cost movements over time are similar across other demographic groups considered in the study, which are women and children. Here I'm presenting the heat map of the diet cost for men, which shows the spatial distribution of costs in the study districts. On average, across most markets, the diet costs are high. However, there are some rural markets that are located further away from the district headquarters. These display relatively lower costs. This highlights that the remoteness is not associated with the higher costs as is evidenced in the literature. And again, these spatial patterns are consistent across different, when prices are looked at each point in the time, as well as for the different demographic groups considered. To summarize, the variability in minimum cost of a healthy diet is relatively stable across demographic groups, and we identify three broader phases of cost trends: high followed by a sustained low, and then again followed by a steady increase in cost. And these are scattered with several short-term spikes and dips throughout the year. And these short-term spikes and dips are associated with price movements of fruits and vegetables, and rural markets consistently exhibit lower costs. And some implications for scaling and policy are that our study identifies this high-frequency price monitoring system as a low-cost and timely tool to track the minimum cost of diet across space and time. And this can guide policies for seasonal price stabilization for healthy foods, improve management of local markets, and enable better targeting of safety net programs. However, this requires stronger partnerships, continuous knowledge exchange among policymakers, local government bodies, research think tanks, and market networks. And thank you, and look forward to questions.
Thank you so much, Anjali. So quickly we'll move on to our second presentation. Second presentation is by Ms. Divya, and she's going to talk about revolutionizing child nutrition, a predictive machine learning model for last mile public health delivery. Divya, floor is yours.
Thank you so much, Chairs. Welcome everybody to this session. I'm Divya from Thematic, which is popularly known as makers of ComCare, an open source platform, but we are a social impact delivery focused organization that have footprint across more than 130 countries as of today. In this session, I will walk you through the engagement of how predictive analytics through frontline data and community interventions has really transformed the way that we look at child nutrition and in the way that we can identify and address it in a more meaningful manner. This work is a result of partnership between American India Foundation and ID Insight, which focuses on a more preventive approach. So as all of us know here, child malnutrition is really one of the world's most persistent battles that we are dealing with. And globally, millions of children are experiencing stunting or wasting before they turn 5 years of age. India alone contributes to a quarter of the burden, which means that 1 in 3 children experience malnutrition. So behind these numbers really is a more deeper issue, which means that by the time that malnourishment is identified, it is rather too late to take rapid action, and communities really need tools that allow for intervention before a child falters to a stage that is in a more negative sense. So the gap that we were really aiming to solve is that frontline workers across the globe gather really deep, rich, and detailed data through growth monitoring, home visits, and various interventions led by a multitude of organizations, sometimes also resulting in duplication of efforts and data. But yet, I think what really is the problem is of underutilization of that data and not really deeply looking at the information that has been gathered. So before we started the intervention itself, one of the primary questions that we were asking ourselves was, what can we really do with the data that we have captured, and how can we turn that more meaningfully in order to identify malnourishment in children between the age of 0 and 59 months. And can we also act on it early to prevent that? So the work was embedded in American India Foundation's existing program intervention in their integrated program, where integrated program community facilitators worked in close partnership with the families in the communities through home visits, counseling, and also a lot of support from the Anganwadi workers in India. Demagi's nutrition solution, which was developed on Demagi's offline and open source platform, the ComCare platform, which formed the digital backbone for this entire intervention, and it supported registration, growth monitoring, home visits and counseling in an Android-based application that was already developed and was in use for a few years before we started this particular intervention. So as the ICF's home visits and centers, they essentially recorded anthropometric measurements, feeding practices, illness episodes, and household characteristics. This information was really synced to the ComCare server, and it became a more continuous input for the machine learning model that I will just talk about. In this way, the model really mirrors the real-world rhythm of frontline services, where the routine data was turned into a more powerful early warning system. So at the core of this model really is the random forest classifier. For those who are interested in statistics, this was a more careful choice that was made to identify and focus on the nutritional status of every child. The model had used a 120-day window for observation in order to identify patterns in growth and household contexts, and it also helped predict the likelihood of malnutrition transition for the next subsequent 60 days. This choice was really crucial for us because the focus was more on prevention, and random classifier proved helpful with the various weightages that we had for the inputs that we had gathered in the program. And although this was significantly harder, I think this is far more actionable from a prevention standpoint. So the model captured multitude of data points, but we categorized and shortlisted about 54 featured inputs, and from those also there were a few shortlisted data points that helped determine the risk for every child. The most important predictors were the child's history growth trajectory that was captured across a time window, height for age, weight for age trends, and this was measured for a couple of consecutive time windows where the data entry was happening. Additional contributors also included age, birth weight, frequency of home visits, parental education, number of siblings that the child had, and the household food access as well. So it is important to also emphasize that these were not causal factors, but these were really patterns that consistently appeared before the growth faltering process was being observed. So from an implementation standpoint, in public health, predicting future health transition among currently healthy children is one of the most challenging tasks, but our model had the potential to demonstrate this in a much more meaningful manner over random classification, and what we saw over the course of the pilot was that it achieved a 3.4x higher precision and under certain realistic conditions, where the 4 highest children per village across the 300 Anganwadi centers were identified. The model also achieved 0.32 precision and 0.48 recall. While these are fairly modest, I think these performance levels are significant in population health settings where early warnings targeted certain interventions. So each child received a risk score of 0 or 1, and these were updated dynamically as the data is collected. I think I'm one slide behind. Yeah. So the ICFs, no, thank you. The ICFs saw a prioritized list of top at-risk children in their own communities in the jurisdiction that they were serving. So there was an Android application that they were already using, and the higher risk children were notified in their mobile application for ease of intervention. And they went about all of those households with extra home visits that were scheduled, which were also automated in the application itself. So for each child flagged, the ICFs conducted about 14 structured home visits over the course of 4 months, where they were also delivering a few different things, including behavior change counseling, guidance on diet to be included, and also referrals wherever needed. The pilot included more than 23,700 children's database across 300 Anganwadi centers in Madhya Pradesh and Odisha. This was in close collaboration with the government bodies and officers who were also overseeing this intervention, and the model proved feasible to really deploy these were also acceptable to families. However, I think the 4 months of intervention proved too short to shift the anthropometric indicators, and growth really takes time, as we all know, and this also required more stable and sustained efforts. I think there were 3 lessons that we really learned. I will take one more minute. One is that I think really needs deeper collaboration among all the partners being present on the ground. 2, I think there are certain performance trade-offs that are kind of inherent when you look at a statistical tool like this. And also generalizability really remains a challenge. So I think the fact that we had to contextualize the model to the particular communities, and now looking at scale, moving towards generalizability is something that we are going to look forward to. A few learnings also from the implementation was the fact that this is a quick scanner while I speak, in case you want a 2-pager on this, but the frontline workers embrace technology, and I think it was really important to ensure that the data collected is not trash in and trash out, because that will really affect the model. And also the counseling needs to be much more specific and contextualized to these communities that we serve. For more questions, I'm always there. Thank you so much for the opportunity.
Thank you very much, Divya. Considering that we are going to have Q&A towards the end of the session, let me just move on straight to the next presentation. Next presenter will be Mr. Rakib Hossain from Khulna University. He's going to, he's going to talk to us about information asymmetry in perishable food markets, the role of principal agent dynamics in behavior market failures.
Thank you so much. Good afternoon, everyone. This is very dangerous time of the day, right? We are standing between the sleep and session, so it's very dangerous to give your attention. Let me try. So you all know about the Bangladesh. It's mostly based on the agriculture sectors, most predominant sector in Bangladesh, and most of our GDP comes from agriculture. A good number of almost 36 to 40% of our labor market completely depend on agriculture market, and so no, in South Asia actually, in agriculture sector, we are one of the largest producer in many crops. So we have a legacy of agriculture in Bangladesh, but if you consider about the agriculture market, especially about the perishable products, perishable agricultural productions, this is mostly predominant by the middlemans. They are Bapparis, they are Porias, they are other stakeholders. They actually control the market. And most of the cases, our farmers sell their produce goods in nearby markets, mostly in the farm gate or village market or union level market, and most very few amounts of farmers, they sell their produce at the metropolitan market or at the district level or upper level markets because of having small holder. So our agriculture market have a higher level of information asymmetry where traders retain privileged price information and farmers sell with limited bargaining power. So word information asymmetry is very important here. Information asymmetry, we normally understand this is one party in a negotiation have better information than another one who actually dominate the market and getting the extra benefits from the utilizing their information. And this systematically lead a low farm gate price, weakening the farmers' income and reduce their capacity to invest in dietary diversity. And so as a result, it's reduce the health outcome. So in low income rural settings, improved income from the fair price is strongly associated with the better dietary diversity. It's highly associated with the higher purchasing power for nutrients food and greater household food security. So if the digital information access has the potential to disrupt information monopolies, improve price realization and strengthen farmers' economic resilience and essential determinants of information nutritional well-being. Existing research has rarely examined how digital information ecosystem and market transparency jointly improve farmers' income pathways that influence nutrition outcome. So this study fills the gap by showing digital information access and market transparency improve price realization, a key upstreaming driver of nutrition sensitive agriculture. So in this study actually we try to find out some questions utilizing a research framework that identify how digital information access shapes farmers' ability to timely and reliable market information. Second, examining how information quality, peer verification, market transparency influence farmers' bargaining behavior in perishable vegetable markets. Assess the combined impact of ICT access and market transparency on price realization ratio, that's we are calling PRR, among small vegetable holders, and exploring how improve price realization and strengthen household economic resilience and contribute to better nutrition outcomes through increasing the purchasing power and food security. So in our study actually we try to use a theoretical framework, that's the information asymmetry theory, principle agent dynamics and behavior barriers that we utilize in our study, and the price rationalization ratio we try to calculate. And this study actually, based on the primary data, we collect 600 farmers' information for this study. Besides that, we conduct some qualitative focus group discussion, key informant interview to get deeper information on the how information asymmetry actually affect the nutrition outcome of households. So if I directly go to the results, that's actually like farmers receive only 76% of the true market price, significantly reduce their income and limiting their ability to purchase nutrient-rich foods. Even small scale in the PRR translate into meaningful improvement in dietary diversity, enabling farmers to buy more fish, milks, eggs, fruits, or vegetables. So in a focus group discussion actually, we try to listen from the farmers like that, and several farmers actually said that when they get good price, they can invest in purchasing eggs, fish, and in the other markets, when the price is certainly get down, they immediately cut off their investment in purchasing the nutrient food for their family. So higher and more stable earning reduce dependence on low cost, low diversity staple, and strengthen household food security together throughout the year. Improving market information and reduce information asymmetry therefore become a nutrition sensitive intervention, not just an economic reform. So here we have some different dimensions, like when a farmer collect information source, trust their information source, like most of the farmers getting information from their from the Beparis, from the traders, most of the cases. When they get trusted information and perceive digital information as accurate, consistently earn higher price, improve their household purchasing power. And behavior barriers, thus as most of the farmers is try to sell their produce goods in same buyer year after years because of their trust, their convenience. But the behavioral sector like trust buyer, fear of loss, the relationship, and the low confidence in the digital tools reduce farmers' willingness to negotiate. And most frequently, information checking behavior, like sometimes I getting information about the market price or for a nutrient product from one market, and when they try to verify with other sources of information, like someone get some information from a traders, they try to verify in the other markets about the cost. That times they have a significant scope of getting more price of their produced goods from the market. And for ICT and transparency, market transparency actually, if the farmers gain higher PPR through ICT and transparency, the result increase in income income directly improve dietary diversity and reduce seasonal food insecurity. So improve PRR, increase income, ability of the households to buy rich nutrient foods, and that directly contribute to their health outcomes. So market transparency, transparent market practice, especially fair, weight, and multi-market price checking, stabilize farmers' earning, produce more consistent consumption patterns throughout the years. So together, ICT access, trusted information, and market transparency operate as nutrition-sensitive agriculture intervention, improve both income resilience and food security for small farmer holders. So here have some policy recommendations that strengthening digital literacy and build trust. Localized ICT price platforms can improve farmers' interpretations to accurate information, raising PRR and enable them a better diet. Strengthening farmers' cooperative, increase collective bargaining powers, reduce traders' dominance, and enhance income stability, support better household nutrition, and creating reliable, local market systems as like dashboards for getting better information, especially the citizen charters or digital dashboards that can directly give updated information about the market. That's reduce information asymmetry, and that's contribute to the better purchasing power or improve their negotiation. So, encouraging price verification across multiple markets, improve income resilience, nutrition-sensitive food security. And moreover, in local context, rural context, like a country like Bangladesh, the market monitoring system, especially in the urban areas, they have some sort of market monitoring system. But if you consider about the producer's perspective, at the rural area, at farm gate, they have very limited scope of price, getting price information or providing price information that's enable them for getting better negotiation to the traders. So I'm ending my presentation here, and I will be happy to answer your questions at the end. Thank you.
Thank you, Mr. Rakib. So moving on. We have the fourth presentation by my esteemed colleague Sweta Manohar, Research Fellow, International Food Policy Research Institute. And she is going to talk about this very interesting topic that I was very privileged to see the first results in Dhaka. So the topic is measuring inequalities in co-coverage of multi-sector nutrition interventions, findings from Bangladesh from one nutrition coverage survey. Sweta, over to you.
Thank you. And good afternoon, everyone. It's a pleasure to be here with all of you this afternoon to present on this study on behalf of my study collaborators from both ICDDRB as well as IFPRI. So, reducing malnutrition, as we've heard several times today already, I think, requires a receipt of multiple interventions, often delivered by different sectors. And these interventions align with strategies reflecting global goals and in national strategies and plans, and are often targeted towards different outcomes, be it reducing vitamin A deficiency, or interventions to improve pregnancy and birth outcomes, or towards reducing anemia in women in reproductive age. But monitoring coverage of these interventions is paramount, given this is where the investments are made towards these global goals, whether it's WHO goals or the SDG2s. The issue is that we don't always measure coverage of all nutrition interventions, sometimes because there aren't coverage measures, say, for example, like nutrition-sensitive interventions, like large-scale food fortification or social protection. But also, there are some issues with certain measures' validity. Say, for example, micronutrient supplementation amongst pregnant women that requires some improvement. And we further measured intervention coverage for single interventions. And so how do we really evaluate whether target populations are being reached by these multiple interventions is the focus of this work. So we work towards answering this with the One Nutrition Coverage Survey, which is a method survey, and has the following objectives. So one was to generate district-level coverage and co-coverage estimates of multi-sectoral nutrition interventions, to demonstrate the assessment of equity in coverage and co-coverage by highlighting approaches to produce disaggregated estimates, and also to develop guidance for implementation considerations, be it design, analysis, and costs, which I can't speak about today. But all of this is in service to inform integrating questions and modules into large-scale surveys. So in terms of the survey methods, this was a cross-sectional survey, and it included 4 different districts in Bangladesh, Dhaka, Khulna, Rangpur, and Sylhet, in 4 distinct divisions. And they were selected to offer some geographical spread as well as urban-rural estimates, representative estimates. Data was collected between Feb to June this year, and we employed a multi-stage sampling approach, first using probability proportional to size to select enumeration areas with the support of the Bangladesh Bureau of Statistics. And then we used simple random sampling to select 20 households per enumeration area. We ended up with a random sample of 3,251 households, and we had a very target population of interest. So women of reproductive age with a recent birth in the past 2 years, children 0 to 9, as well as adolescents. So data collection was designed to cover a range of questions related to receipt of nutrition interventions. We had household questionnaires that collected a slew of socioeconomic status information, as well as household-level interventions such as access to wash, social protection, nutrition-sensitive agriculture, and also access to fortifiable food vehicles. In the women's questionnaire, we had modules for both the woman and the child, and it covered a range of questions related to receipt of ORS, deworming, micronutrient supplementation, nutrition counseling, and so forth. And the measures we use, fundamentally this was focused on coverage. So those were the survey questions of focus, and the questions were both standard questions from existing large-scale surveys like the DHS, MIX, or LSMS, but also included some piloted measures that for interventions, like I said, that maybe don't have nutrition coverage measures. Oh, and I should say that everything included in this in the surveys was really mapped to the Bangladesh policies and programs. So in terms of analysis, we look at intervention coverage and co-coverage, which is the clustering of interventions, in two different ways, both by life stage as well as by public health program. And so in terms of life stage, we looked at different life stages: pregnancy, early childhood under 2 years, adolescence, and preconception. And with second, with the interventions that are grouped by major public health program, that they aim to address. So they usually address a major public health problem, so including stunting reduction, anemia control, and then vitamin A deficiency control. We estimated coverage using and offering a sectoral lens, and then also measured co-coverage, doing a simple key count of interventions for each life stage and by nutrition problem. And we also computed standardized scores from 0 to 100 to be able to compare co-coverage between life stages as well as by public health problem. In the interest of time, I'm just going to walk you through a smattering of the results. So to start us off, just to look at coverage, not co-coverage, but offering a sectoral lens. And we focus in on the coverage of a group of interventions that are targeted towards the pregnancy life stage. So in this, we're looking at households with women of reproductive age with a birth in the past 2 years. That's the target group. And on the left, you'll see a range of 19 interventions. And this is typically targeted to this life stage, mapped to national nutrition plans and policies in Bangladesh. And in the yellow cluster are those interventions related to the health sector. So this is, anything from micronutrient supplementation or ANC services and nutrition counseling that are all targeted towards this target population. And then the next in the pink bars are the social protection interventions. So this includes food and cash targeted to pregnant women as well as their households. And then in the blue are the WASH indicators, which include access to improved water, sanitation, and hygiene. And then finally, the indicators related to household access of fortifiable food vehicles, namely wheat flour, oil, and salt, are in the green. So overall, we see that micronutrient supplementation coverage, specifically iron and calcium, are about 80% and are some of the highest in terms of coverage other than being weighed. Otherwise, half or less of women are receiving health sector interventions intended for this target group. Target social protection coverage of pregnant women is low, and for WASH, we see that hand washing facility access, that's access to water and soap, is less than 50%, and there's about 90% coverage on average of have access to an improved water source. Access to fortifiable food vehicles is generally high. And so on average, 7.8 interventions out of the 19 interventions targeted to pregnant women are being received. When we look at co-coverage of interventions during pregnancy, and we just use a raw total number of interventions account, we noted that despite there being a total of 19 interventions for this life stage, no one received 13 or more interventions, and 66% received 8 to 12 interventions. Now, when we use a standardized percent of interventions, it allows us to compare the percent of population by co-coverage levels, by life stage, and here we use different cutoffs. So we created cutoffs for those receiving no interventions, which was about a little less than 1%, and you can't see those bars there. And then we did a cutoff for less than 30% in the orange, and those receiving 30 to 60% in the light green, and then those receiving greater than 60% in the dark green. So close to 40% of the major target population groups, if you look at the life stages, are receiving about 50, sorry. Oh, okay, I'm back. Okay, so if we look that at close to 40%, if you look at the dark green, close to 40% of the major target population groups are receiving greater than 60% of the recommended interventions for their life stage. And greater than, about 56% of women are receiving greater than 60% of the intended interventions during pregnancy. Between 7 to 10% of each life stage target population is receiving less than 30% of interventions intended for that group. So I'm going to wrap up very quickly here. So just to say that inequalities in co-coverage by health exists and follows the kind of patterns that we would expect. And we see no urban and rural differences. And we do also see inequalities in co-coverage of households receiving greater than 60% of multi-sectoral interventions. And this inequalities do exist by mother's education level. So in terms of the key takeaways, we're just really thinking through, and we hope we've made a point about how co-coverage as a method is transparent and can be utilized if common indicators are used, and they may be comparable across time and countries. Measuring coverage of key multi-sectoral interventions and assessing coverage using a sectoral lens and co-coverage can help policymakers identify which target populations are receiving sets of recommended interventions. And finally, co-coverage indices are country-specific and survey-specific. Okay, and with that, I thank you, and I guide you all to visit our website where you can also access the tools used in the One Nutrition Coverage Survey. All right, thank you.
Thank you. Okay, let me proceed and introduce the next speaker, who is my colleague from another country office, Mr. Saeed Azim. He's from Afghanistan Country Office, UNICEF Country Office. He'll be presenting to us Afghanistan's Community Nutrition Sentinel Sites, CNSS, a Model 2 Crisis Responsive Surveillance. Over to you.
Thank you so much, G. It's my pleasure to our panelists like you and my colleagues. So, good afternoon, colleagues. What I am going to present is our journey to reach a surveillance responsive system which fit the humanitarian cycle planning and intervention. So first I want to show you what's going on in Afghanistan. As you may see, the stunting level is still high. However, there is a good progress during the last 20 years. But on the other hand, we can see the wasting stagnated. Still, we have a big issue with wasting level. Just I calculated 1 out of 12 children which are wasted globally are in Afghanistan. 3.7 million wasted children. One in every 2 children, they have stunted. 4 out of 10 women, they are malnourished, and you can see the multidimensional child poverty is 70%. The rational objective, what was the reason behind establishing this system? First of all, as you can see, is a huge emergency nutrition crisis in Afghanistan. We need a system that is responsive and help us to monitor the situation. The previous mechanism, they were lacking any routine information to monitor the situation, in particular for wasting. Over reliance on expensive smart survey was another main reason, rationale behind it. There was no mechanism, however, there was some national anthropometric survey to monitor or to see the seasonality and early warning, which is a nature of wasting. And as you may know, in Afghanistan, we have a de facto government. Maybe you hear something, but it's very difficult to work and very difficult to do household survey, go to house. As an example, to understand more the polio is a house-to-house campaign. It's not possible because of that issue. And for sure, we know there is a funding constraint. As I mentioned, for cross-sectional survey, it's time-consuming, it takes time, and it's very difficult to rely on them to proper planning and decision-making. When we have a decision gap, we cannot plan properly, and we had experienced that the estimated caseload was overreach or underreach. It means the overestimation or underestimation. And we know that if there is a disruption of this survey, definitely there is no data to do our humanitarian planning. So we decided to have a resilience nutrition sentinel site community-based system which is continuous and provide data in regular basis in different seasons, which is 4 times per year. To tackle with that, to achieve that goal, there was 2 main problems in front of us. First, politically and culturally, it is acceptable to conduct that kind of community-based sentinel site. And second, considering the shrinking of the fund, it should be low cost and sustainable. On the other hand, we shouldn't make these political people happy, but people like you, another struggle was to make these people happy. So about all of these statistical terms, it should be compatible to make you people happy. So we struggle with those things. We come up with the design of Sentinel site, which you can see the dots are the number of sites, 401 sites in all districts in Afghanistan. It's 19,000 cohort. Each quarter we're collecting data from these sites. And for your information, to understand the scope or the scale of this Sentinel site for anthropometric, we only collect data based on the national survey is 23,000. The Sentinel site is a health post which community health worker, volunteer worker, we train them using a standard SMART methodology. But after training, they get a field test, a standardization test. After during the data collection, quality assurance. After the data collection, we did the plausibility check using the Moana, which is developed by Global Quality Support Unit, Global Support Unit of IPC. And we come up with this data and it's validated with different working group. This is the methodology and the way we are collecting. The link is there. Netroverse, which is the GSU unit of IPC. We use that methodology. And for age estimation and indicator consideration, we developed the community-based modified event calendar to have correct age and the ethical standard of UNICEF also applied. I am escaping the result, which I am very interested and we are proud of having that one. We had 12 bulletins, which is not only to inform or support an early warning system, it's hugely contributed to advocacy and fundraising during this time. It's a kind of trust that is the routine monitoring system is available, that the donor community can monitor and can see what's going based on their the resources. We use this information for the multi-sectoral analysis, humanitarian response planning. We did IPC acute malnutrition last year and this year for a SMART using this Sentinel site, and you see the map. The first map I showed, the result was from this Sentinel site, not survey. And finally, the big milestone is we integrated diet quality questionnaire for IYCF and early childhood food insecurity within a matter of months into national system, this Sentinel site. Challenges, to be honest, our main challenge was to convince our office colleagues to go with this alternative data model. But there was definitely another issue that the partner, which was part of the system, they were really want to have everything. Perfectionism kill innovation. Please remember this one. Don't overthink. Don't paralyze doing much more analysis. So, lesson learned. This is, I think, the last part, I believe, on one slide. I believe on these terms or on these approaches. We need to involve every stakeholder, including community, when during the design stage of our system. Any system, it's not only, we can generalize it for any system we are doing. Inclusion and collaboration, it's very important. We should appreciate the contribution of everyone, and to have we should be also passionate. We shouldn't rush to show something fancy. It takes time to make people own it. When our Sudeep, I think he was mentioning, RT also mentioning that credibility. If the people don't own anything, any system, they don't trust the data. If you have the perfect scientific measure for that, they should buy it, they should own it. And we should show the use of the system, that how the people can benefit. How the system can help them to ease their work. We need to listen. Very simple thing, but most of the time we are not applying. We need to listen, and that's one of the points that we were successful. Before scaling up, we need to invest much time. More than 1 year, we tested, modified, listened from the field, not from experts, they're from the field. 80% of good things come from them. We need to listen. Again, and finally, as I show you in the first slide, all of the estimation is done based on this community sentinel site. They are estimation anyway. And this sentinel site inform humanitarian need overview and planning cycle for Afghanistan nutrition. By integrating that quality and IYCF, what we did, we can do secondary data analysis using the system. And finally, Global Nutrition Cluster recommended using this system in absence of a national service as alternative data, so which has a huge impact in our future, how we think, how we work on the information part. I have to appreciate UFCDO, which funded this my mission based on First Food Initiative, which is currently started, and I should thank United EU, European Union, for supporting this community sentinel site. Thank you so much, colleagues, for your time, and have a great day. Thank you.
Thank you so much, Saeed. Okay, so last but not the least, I would like to invite Lion Shah Fanwar, Program Manager, Meghalaya Early Childhood Development Mission, to give her presentation on community-led nutrition monitoring in Meghalaya, a scalable model for locally rooted gender-responsive data system. To you, Lion.
Good afternoon, everyone. I am Lion Panwar, Program Manager Nutrition for the Meghalaya Early Childhood Development Mission, India. Today, I am presenting our work on community-led nutrition monitoring in Meghalaya. This is a model that is scalable because it builds on the existing self-help group network and also allows replication across districts with minimal resources. It is gender responsive as it places women at the center, thereby empowering them. And it is at its heart, a model, that is being guided through with the community, whereby the entire data collection process, right from the discussion and putting into action, is led by and is led by the community. So a little bit, yeah, I think it's okay. So Meghalaya has a very distinctive context. We are a predominantly tribal state with our communities spread across difficult terrain and remote settlements, where information and access to services is often challenging. These realities shape how families live and how nutrition systems actually function on the ground. So for many years, nutrition data has come from multiple sources, but it hasn't always aligned. So the inconsistencies and gaps, especially post-COVID, makes it very difficult to understand the real conditions of young children and mothers, thereby affecting effective policy planning. So to address this, Meghalaya has been moving towards a more equity-focused, human-centered governance approach, one that recognizes local realities and ensures that every woman and child is visible in our system. So in such a setting, community-led monitoring is essential, because this will allow SHG women and local communities to generate accurate, grounded data, and also to use that information in ways that actually reflect their realities. So this can create a sense of ownership, accountability, and also makes a stronger foundation for nutrition action across the state. So the approach was that Meghalaya undertook the state-level community-led nutrition survey, the first of its kind in the region, across 7 tribal districts in Meghalaya. The core principle was simple. The people who would be closest to the mothers and children would be the ones generating the data. So for this, we mobilized the SHG women because they are deeply rooted in the communities. Their presence in every village made it possible for us to reach households in remote and dispersed areas. Another effort was the strong institutional convergence. We had in various departments in our state support us. We have the Meghalaya ECD mission anchored the initiative, but of course it worked closely with the Meghalaya State Rural Livelihood Society under the NRLM, and then the MLRF Fellowship, the Society for Social Audit Transparency, and Social Welfare Department. Each institution brought unique strengths, right from community mobilization, field oversight, then analytical support. We were also supported by our technical partners, the International Institute for Population Sciences, Mumbai, which is the nodal agency who conducts the demographic health surveys in India. They guided us with the sampling design, and we also had Indian Institute of Public Health for the training of trainers on ethical data collection, anthropometry, and using of digital tools. So even though this work was led by the community, the support of these partners gave us the confidence to actually, believe in the work that we will be able to generate reliable data which can be used for planning. So when we look at our tools, our questionnaire was based on the NFHS questionnaire, but we had tailored ours to collect information that we wanted to know immediately on the ground, and this was concerning household profiles, maternal care, infant and young child feeding, access to ICDS services, and child nutrition. These modules would help us understand family practices and the system, the service environment around them. So since we are using the SHG women for this data collection process, it was important for us to handhold them to make them confident as data collectors. We had a 3-day structured training for women where we focused on 4 objectives. The first was ethical data collection, how to ensure privacy, how to make the respondents comfortable, and then the second was on using the CAPI tool. This was an offline capable tool which was also translated in local language. And considering our difficult geographical terrain where network connectivity is limited, this was one of the things that enabled us to capture the information. And we also focused on anthropometric standardization, where each of the SHG women undergone the technical error measurement, the TEM standardization. And on the last day of the training, we actually had a field testing just so that they can practice in real life settings. So we also understand that just training itself is not going to be enough, especially for working on a challenging terrain. So right at the start of the survey, we had refresher sessions. We also had field mentoring, and there was an active WhatsApp group, and then little guidance notes just for them to, as a gentle reminders. So we could survey around 6,335 households with 41% of children less than 2 years and 55% in the age of 2 to 5 years. As you can see here, there was also community sensitization before data collection so that respondents are more comfortable with taking part in the survey. And there was also spot checks and field supervisions happening on the ground. So with regard to some of the findings, we could see that dietary diversity remains low, especially among younger children in lesser than 2 years. And this was also strongly backed by the low social economic background, and the educational background of the mother also strongly influenced the feeding practices. There was also a large district variations in child diets and feeding behaviors, which help the state to kind of like understand that even within our own state, there's like a widespread difference from region to region. ICDS services were widely accessed. However, it makes us understand that this platform can be further strengthened for more action. And of course, when we look at household features, like a lot of our households depend on wood, and there's still limited pipe water access. But encouragingly, most households had toilets. So from this, we can understand that it's not only the nutrition that is important, but also the living conditions of the family to, kind of like help us understand what can shape the child's environment. So there were a lot of challenges in engaging SHG cadres, the questions about their capability in engaging them for a survey. So whenever they had the digital literacy gaps were addressed through hands-on mentoring and field testing. And of course, the difficult terrain, as I have already mentioned, that we developed offline tools, translated in local language, so it becomes easier for them. And anthropometric accuracy, we ensured that each SHG woman had undergone a TEM. If we find somebody who could not pass the assessment, then we leave them out of the data collection process. And this helped to bring about confidence in the SHG women. Initially, they started out a lot of hesitation, but then they gathered the confidence as they went on with proper support and monitoring. So the communities also viewed the findings as their data. So they became local nutrition monitors and advocates. So when an SHG woman was actually measuring a child in one remote village in a district, she was not just collecting data for a distant policy maker, but she was gathering evidence to use that information to demand more services for her own community, thereby holding systems accountable. So this also gave a strong foundation for district level planning. So again, the infrastructure, the strength is using and developing these SHG enumerators, where the knowledge remains in situ, remains in the community, and can be taken forward for action. The quality was being ensured by standardized training and proper supervision and monitoring. And the data was also used by in the village forums through the village health council to discuss the realities of their own communities. I would be happy to take more questions after this. So I would just like to thank that our Meghalaya ECD mission under the leadership of our Principal Secretary, Dr. Sampat Kumar, and the guidance of our and dedication of our whole team. And I would also like to thank the Delivering for Nutrition Conference for having given us the platform to present our work. Thank you so much.
Thank you so much, Ms. Fanwar. Wonderful presentation. So at this point, unfortunately, my co-chair had to leave. She had a urgent meeting, and so I'll lead the question and answer session. Before that, I would like to invite all of the presenters to kindly take their seats at the dais, please. All the presenters, if you may. Thank you. All right, as the presenters settle in, so we have around 17 minutes, and I want to be on time. I don't want Aisha to be angry at me going over time. So just a quick recap for everyone what we have seen today. So this session was on data system at scale, right? So we have seen different kind of data collection method and how they are appropriate for, sometime it could be context specific, or it could be, at scale in true of its meaning. So it could be applied to other places as well. So that's the question we would like to have. So first we saw a low-cost, high-frequency price monitoring method in Bihar and India. Second, we saw a predictive machine learning model to forecast malnutrition among children. Third, we saw an in-person survey and also a mixed method to understand the price asymmetry to address the principal agent problem in Bangladesh. Then we saw a community nutrition sentinel system for surveillance method for crisis responses area in Afghanistan. And then we saw a community-led nutrition monitoring model in Meghalaya. So yeah, I think overall, so I would like to open the floor right now. So let's be on time, and please introduce yourself. Make your intervention very specific. Please specify the presenter that you'd like your answer from, and then we'll collect a few questions, and then we'll come back to the presenters.
Thank you, Mugdo. There's a question from an online participant for Rakib Hussain, and he asks that, did you find farmers from the same village selling their products at different prices? If yes, are the price differences significant? Also, did you observe monopoly attitude from the village trader? So that's the question. And another question for Rakib. As far I'm concerned about nutrition, we all expert groups have perspective menu, not considering the cost purchasing power vegan and vegetarian groups. Largely we prescribe as if everyone in the world are living in the same place and same belief. Does the nutritional guidelines of India consider these perspective while developing nutrition guidelines considering above consideration? I think it's more of a comment, but just wanted to put that out.
Thank you so much, Aisha. Yeah, we'll take a few questions from the floor, and then presidents will address them.
Hi, I'm Shuman Chakrabarti from IFPRI. My question is also for Anjali. Really enjoyed your slides and your presentation. Thank you so much. So the graph that you showed on the prices over the months of the year showed the cost of the recommended diet. I was wondering how that compares to the cost of the actual diet that's being consumed, and so that if it can give us some insights on what kind of adaptations the households are making in order to cope with the changing prices.
That side, yeah.
A question for Anjali as well. My name is Mehra Bakhtiar from IFPRI. So you mentioned seasonal price support as a potential policy recommendation. So I was just wondering if you could give a bit more details on that. Like, is it like crop specific, product specific? And the other question was on, you showed that some of the remote areas over there, it doesn't look like the cost actually is higher compared to more connected areas. I was wondering why that is. Is it because they're producing those items and therefore the cost is not as high? Is it a supply side factor, essentially? Thank you.
Hello, this is Naushiba from BRAC, Bangladesh. I want to ask to Anjali that about that you have mentioned that 600 something market has been surveyed for a certain prices of certain food, and my question is very basic, that is the sample size of is state-wise representative? It was very much, I was a little bit confused because of the state size of Bihar and the sample size. So I need a bit clarity.
Thank you. We'll take one more question this round.
Hi, my name is Molla Amrid. I'm from BRAC University, Bangladesh. So my question goes to Divya from Dimagi. So I would like to know whether you have planned to use like agent-based modeling and other kind of like weather forecasting methods, like ensemble techniques for like prediction of nutrition outcomes, or like the way price is changing and how it will change the behaviors of people in a system, and then what will be the nutrition outcomes like obesity or malnutrition in the long run. So do you have any plan on that?
Thank you so much. So I will come back to the presenters, and maybe using my power as a chair, I'll add one more question to my colleague Sweta. So maybe it would be very interesting to hear from you, Sweta, from your presentation that I understood. Right now we are living in a world there might not be any DHS anymore. We don't know when it is coming. And so the value for data collection and especially service like the way you all have described, it's more important than anything right now. So what survey methods like this, would it be able to complement DHS or even like, go one step further and make it better, and maybe at scale other countries could also use those kind of methods? So yeah, I will start with you to address your questions.
Thank you for your questions. For the first question from Suman, we're actually in the, in the subsequent times, we'll be actually linking this estimated cost of diet with the actual cost of diet. Although on consumption side, we do not have the data at the same frequency as it is for the prices at markets. And so I don't really know what is the exact difference between the actual cost and the estimated estimated cost for the required diet. But from couple of discussions that I've had with my colleagues who have been leading the household food consumption data, would hint that there is not a substantial difference between the estimated cost of the recommended diet and what is the actual cost of diet on the household consumption side, which already indicates that, but at the same time, on the diet side, the nutrient adequacy is not meeting the recommended healthy diet. So on an expenditure-wise, there's not much difference, but much of this expenditure might also not be spent on consuming healthy diet. So there is a lot of opportunity for nutrient communication information and several behavioral communication, behavioral change communication strategies to help households and individuals to allocate their expenses or food expenses in order that they meet their adequate diet requirement. And I might also just quickly talk about the sample size. We selected these 2 districts to facilitate the interdisciplinary research in communication with the local government bodies, and the sample size is representative at the district level, but not at the state level.
Thank you so much. I would like to answer that questions from my presentation that I try to cover during my presentation. We cover with the farmers who actually produce vegetables at the rural level. Particularly, we analyze their sales behavior, like where they prefer to sell. Most of the cases we find they love to sell at farm gate to some traders who go to the village level to collect their produce crops and goods because they have some behavioral factors, because they trust on them, they get some advance money for their produce goods, and sometimes they have to carry their products to the nearby market. So avoiding those things, they love to prefer to sell their produce goods at farm gate, particularly to the buyers. And if we think about the sources of information that's actually farmers get to sell their produce goods, most of the cases they get information from the traders, or they get information from their neighbors. So most of the cases they have a potential threat of misleading information. We found that someone who trusts on the traders' information, they have negative impact on price realization. That means they have some tendency to hide some information so that they can purchase their produce goods in lower price. So this is how actually we try to collect data from the farmers. to analyze the price realization and the gap actually the metropolitan market price and the local market price. So if someone carry their products to metropolitan market rather selling in the household or farm gate, they have potential to get more price realizations. So this is how we can answer this question. Thank you.
Okay, thanks for the question. Okay, yeah, so we are definitely living in a time where data needs are still remain critical, but there are constraints, you know, with DHS winding up. But there are other population-based surveys like MIX, and there's also many countries that are taking on national nutrition surveys of their own. And so we see the One Nutrition Coverage Survey, I mean, it's twofold. One is that it offers governments that are interested in monitoring coverage data to utilize these indicators that are both a range of standard indicators as well as newly developed ones if they are interested in measuring, you know, a range of multi-sectoral nutrition interventions. It also offers, you know, a collection of tools for what it might look like if you want to incorporate all the modules within a national nutrition survey. I think overall what we saw was that the cost to the burden in terms of time is relatively low in terms of just collecting coverage data, so about 20 minutes or so, and they reported, you know, not finding these questions particularly difficult to respond to. And we also found in terms of financial costs, the major portion of the budget really went through to the design of the survey. So I think like what the One Nutrition Coverage Survey offers is that some of that work in terms of collating measures across the multi-sectoral nutrition interventions, we offer these tools that could be taken up by governments and also costing information that could help inform prioritization of coverage indicators that, you know, governments might want to monitor over time.
Thank you so much for your question. To be able to identify the child malnourishment, the preferential choice was to use the random forest classifier because there were certain weightages that were looked at for all the indicators and inputs that were collected. So this was more beneficial in terms of the precision that we were looking at. But I think for aspects such as, let's say, in order to monitor the high-risk pregnant women or to be able to look at other warning systems, there is interest in looking at other model types and statistical methods, and I'll be interested to talk more about what specifically you might have in mind.
All right, let's take one more round of questions, and please be brief in your questions so that our presenter will have some time to respond to that.
Thank you. This is Masina from BRAC University, Bangladesh. My question is to Shweta, that I mean, probably how do we meet this inequality of nutrition coverage data set? So, I mean, maybe probably it is better, I mean, to focus on better diets for nutrition, so putting at the diets in front, also going beyond dietary diversity to also unhealthy food consumption, and then looking towards other nutrient indicators, nutritional interventions by age group and other priorities. Thank you.
Yeah, thank you. Next question, please.
Hi, Stella Nordhagen from GAIN, and my question is for Divya. You mentioned that the precision of your model, I think you said, was about 0.5, and that it was significantly better than random. But I was wondering if you could benchmark to what you would ideally want to see for this type of model, or what a particularly well-performing model does, and also if you could speak to what could be done to improve the precision in the future. Thanks.
This is Anas from National Hospital, Sri Lanka. So I'll make my question very short to Divya. how do you measure the model prediction translated into real improvements in child nutrition outcome on the ground? So I wish to know whether you have covered this in your study, or what could you do that for that? Yeah.
I'm Anjali from IFPRI India. I have two questions, one from Ms. Sweta. When you talk about co-coverage and a higher number of interventions, so did you find any particular factors which are leading to higher intervention compared to the lower intervention groups? And my second question is from Ms. La. While this is very interesting that you led the community-led interventions and data collection approach, so I was curious to know whether you collected the data on the household nutritional dynamics of those data collectors also, because they are also part of the community. So might be being the trainer, they may have better nutrition or something. So I just wanted to know about it. Thank you.
Thank you. And we'll have one last question. Please go ahead.
Thank you. I'm Shahriar. I'm from CARE Country Office in Bangladesh. So I have two questions. One is for Anjali, another one is line share. So for Anjali, what are the main challenges you have faced, especially when implementing this high frequency price monitoring tool? Especially you have split it on the three phase you have demonstrated. This is one. And number two, that in what ways the community-led or gender-responsive this model or tool empower the local community when we consider this local-led monitoring system. So in which way this will empower the community, right? Thank you.
Thank you so much. So many of them are very good questions, and some of them are good comments for you to take. We don't have much time, so I'll add one question to Saeed as well. So the Afghanistan, it's remarkable that Afghanistan had this survey, and my quick question to you, when is the next one coming, and what do you think is the feasibility of having it continuously for Afghanistan? So that would be my question. So now to you, just 10 to 20 seconds remark, if you can address whatever you want. Thank you.
Thank you for the question. So I think the point was 0.5, and I think the idea is to do it in 2 levels right now. When we have the next opportunity to improve the model, the idea is to look at how we can generalize the model to be able to put this model into use across different communities and not specific to one community. So I'd say that even if we target a more generic model at the same accuracy and precision value, that would still be a win for the first round. And I think the second round would be going a bit further up, where the idea would then be to see if there are weightages that we can modify for the different inputs, and that would then have, like, what kind of implication would that have then on the precision and the model, thereby to suggest not just the top 4 high risk or at risk children, but probably just highlight in terms of like priority who are the children who are at risk. So that's broadly what the current thinking is, and I
I think we can have chat during the tea. Yeah, just quick response. Saeed.
Okay, thank you so much. Just for community center sites, we are collecting data 4 times for anthropometric, once for diet quality, and 2 for food insecurity in post-harvest and lean season, which understand the dynamic of food situation. Regarding the sustainability, just a very quick one. One round of this sentinel site costs 10% of one smart survey. We are fully confident that it will be funded, and last year we were donor reaching us to if you need fund. So it's very well taken with donor, and we are very confident that we will have a long-term funding for this program, which is very sufficient. Thank you.
Sorry, so we're on time, and I would like to conclude the session by thanking the presenters and thanking everyone on the floor and also online shared your question and comments. And I hope you guys will have some time to talk to the presenter during the tea break as well. Thank you so much. Thank you, everyone. Thank you.
Thank you, Mugdha bhai. Please hand over the certificate of participation to our participants, and please come forward for the group photo. We have a tea break, but after the tea break, we have a very exciting session. This is something very new that we are doing in D4N this year. I will not give you more details, so you come back in 30 minutes for that. And for our virtual presenters, please join again in 30 minutes. That is 4 p.m. Nepal time for the session on research reflection. So see you all in 30 minutes. Enjoy your tea.